Good afternoon. Welcome to the liquid nitrogen cryotherapy in the treatment of precancerous and cancerous conditions in the esophagus, presented by Dr. 𝘃𝗵𝗶𝗀𝗆. My name is Patrick Clary, Eastern Regional Business Manager for True Freeze Spray Cryotherapy with Steris Endoscopy, and I will be your host for today's event. During the event, if you have any questions or comments, please submit them using the chat box at the bottom of your viewing screen. Questions will be addressed at the end of the presentation. We're honored today to have Dr. 𝘃𝗵𝗿𝗀𝗆 joining us. Dr. 𝘃𝗵𝗿𝗆 is the current president of the Parkview Cancer Institute. At Parkview, he's also the director of Interventional Endoscopy Fellowship Program, as well as the Interventional Endoscopy, Oncology, and Surgical Endoscopy programs at Parkview. Dr. Sharma also serves as the chair of GI Oncology in Fort Wayne, Indiana. Dr. Sharma has extensive experience in treating patients with precancerous lesions and cancerous conditions in the esophagus using liquid nitrogen spray cryotherapy. Dr. Sharma, the floor is yours.
Thank you. Welcome, everyone. I hope you're having a great weekend here with ECAN, and I appreciate everyone tuning in. I recognize that we're coming from a variety of backgrounds for individuals listening to our course. So I hope you enjoy our sessions here. I'm going to share my screen so you have the opportunity to go through the slides with me. And at the end, we'll have time for questions and answers. So our learning objectives today will be to get an overview of cryoablation technology. I recognize that there are individuals from all walks who are tuning into this talk, and some may have heard of cryoablation, some may be currently utilizing cryoablation for treatment of patients, or a patient is receiving cryoablation, and some individuals may never have had exposure to this amazing technology. And for this opportunity here, we hope to give an overview so individuals recognize what cryoablation is. Additionally, we'll talk about palliative indications for cryoablation and its role for palliating in patients who have esophageal cancer. And then finally, we'll talk about salvage therapy for the treatment of esophageal cancer. Throughout the various sections in these three learning objectives, I will give you evidence-based background as well as science in where we are and why we have certain applications of this technology and what's there today to support its utilization. So jumping into the first section, we're going to talk about the overview of cryoablation technology. So cryoablation is a different method of ablating esophageal tissues. In this case, it can be used for both Barrett's esophagus as well as esophageal cancer, both squamous cell carcinoma and adenocarcinoma of the esophagus. The technology works by using liquid nitrogen, which is super cooled at negative 196 degrees Celsius atmospheric pressure. Once it is this cold, the liquid nitrogen then is sprayed onto target tissue. When it's applied to human tissue, it causes direct cell injury by intra and extracellular ice formation, which leads to cell death, not as we're spraying these tissues, but actually as the tissues thaw. So very much like getting a thermal, a freeze injury when you're out in the snow with frostbite. What happens is the tissues get extremely cold, and then as they thaw, their free oxygen radicals come into the area and the cells undergo apoptosis or cell death. What's interesting about this type of ablative technology, different than thermal technology, for example, the extracellular matrix is actually results in its normal growth, regrowth, and minimal scarring. And even when we take biopsies after ablating, that extracellular matrix is preserved. So actually there's no actual destruction of that. It's the cells that die themselves, but the architecture remains the same. Here's an example of the catheter, and here's what the machine looks like. The catheter goes through a standard upper endoscope, or can go through other types of endoscopes as well. The catheter then is connected back over to the machine, which you see on the right-hand side of the screen there. And here's further examples of what's going on inside the machine. So you have super cool liquid nitrogen that's inside of the machine. You also have an active suction area inside of the machine, which is attached to a catheter. This catheter is fenestrated, meaning it has holes inside of it, and it actually goes down the patient's mouth and into their stomach. This allows for active ventilation, which is a key part of the process that provides the safety for delivering this type of ablation. So the catheter would go through the endoscope and deliver the liquid nitrogen. As the liquid nitrogen then heats up, it goes into a gaseous state. And the goal of active ventilation is to remove that gas from the patient so it does not cause harm to the patient. Here's an overview of the procedure, and we'll actually show you a procedure as well. So we identify the area that we want to ablate. In this case, you're seeing an example of Barrett's esophageal tissue. Once it's been identified and recognized by an experienced endoscopist, we then will hit the gray suction pedal, and this is after the catheter is down through the patient's mouth when they're sedated and asleep and comfortable. That catheter is positioned in a specific area, and as it's positioned, those holes inside of that catheter, that suction catheter, allow for active ventilation. We then hit the gray suction pedal. As you can see here, we have an introducer to the channel of the scope. The other pedal allows for ablation, and so we're actively pressing on that pedal as long as we'd like to ablate. And then we hit the target tissue with spray liquid nitrogen. There are some standards around dosimetry. What's interesting and also very useful for experienced surgical operators here is the dosimetry can be varied quite a bit. But typically for benign lesions such as Barrett's esophagus, precancerous lesions, we'll do 20-second cycles or up to 30-second cycles with freeze-thaw cycles ×2. So that means applying liquid nitrogen for 2 20-second cycles with 1 minute thaw time in between. For malignant lesions, we actually apply more spray cryotherapy, and that's done for 30 seconds, and then we have 3 cycles of 30 seconds. Again, we can vary this depending upon the actual patient's anatomy, and we can personalize the treatment to the patient depending on the degree of cancer that they have, how obstructed the lumen is, the extent of the cancer, and the total amount of area affected. What's also great about this technology is we can actually treat tumors high in the cardia because we can apply it directly through the scope, retroflex the scope in the stomach, meaning point it back upwards, and actually spray directly through that area. And here's an example of one of my patients being treated with cryospray. So in this patient, they have Barrett's esophagus that's residual after treatment of esophageal cancer. And here you're seeing what it looks like in real time. So we have a 72-year-old male with a T2N0M0 esophageal adenocarcinoma, 15 weeks post-chemotherapy and radiation. He's not a candidate for esophagectomy. He had a complete resolution of his disease, but he's on Coumadin. At 8 weeks, there's a slight uptake on PET at the GE junction. We took a look with an upper endoscope, and we found that there's no residual cancer, but there is Barrett's esophageal tissue left behind. We do not want to leave Barrett's tissue in place after it's turned into cancer once. As you may have heard from prior lectures, this will likely turn back into cancer again. So we want to treat this residual Barrett's tissue, which you can see here. We've placed now this guide wire, and now we've placed that suction tube that I explained to you before that has holes inside of it, and active suction has started. Now we're finding the target area and spraying with a 30-second cycle because we want to be very aggressive to treat this Barrett's tissue, which has already turned into cancer once. We do not want recurrence of the disease. And here you can see spray being affected. So that's that supercooled liquid nitrogen, and it's hitting onto those target tissues. We cover the area for 30 seconds using that foot pedal to apply the ablation. We then have a 1 minute thaw period, and oftentimes we'll see hyperemia or turning red of the tissues, which is exactly what we want. Sometimes tissues will even bleed slightly, but most of that bleeding is very self-limited. And that's essentially what we want, because that means that free oxygen radicals are getting into that tissue as it thaws, and it's causing cell death of the target tissues. Here you can see a second treatment for the same patient. And in this case, we chose to do 3 30-second cycles with 1 minute thaw time. And you're seeing now some of that redness and that very minor amount of bleeding that occurs in some patients. And again, there's nothing that we need to do for that. It's very self-limited. We don't typically have to do any interventions on the bleeding area. And then here's the third treatment for that patient. And this is very well controlled by the operator and allowing us to deploy different amounts of ablation depending upon how much we need to ablate for each patient. So what I like about that for my patients is we can personalize and tailor it as needed. Here's a nice diagram which shows the wall of the esophagus here. So the esophagus really has 4 layers. It's a little bit different than the stomach, which has 5 layers. And those 4 basic layers are the mucosa, the submucosa, the muscularis propria. And so when we take a look at that in more of a defined way, we want to know what areas are affected by ablation. So that very first layer, that mucosa, right before the second muscle layer, the muscularis mucosae, that area often is where the Barrett's tissue and abnormal tissue arises from. And as that tissue transforms into cancer, the cancer grows deeper into the wall of the esophagus and also spreads along the esophageal wall. As it gets deeper into the submucosa, that's where you have lymphatic and blood vessels, which then the esophageal cancers can sometimes escape and metastasize. The good news is, because it grows from the inside out, it allows for ablation technologies to treat both the cancer and or the precancerous states when it's in early stage. And so this diagram shows what radiofrequency ablation depth looks like. So that's thermal energy that we use typically in Barrett's esophagus to destroy Barrett's esophageal tissue. Some of you may have also heard of PDT or APC, which are different technologies that are also ablative technologies. They may have some penetration a little bit deeper than the muscularis mucosa. Cryoablation, however, goes significantly deeper than any of those technologies, which has a value. It especially has a value when we talk later on about salvage treatment for more advanced cancers that are deeper in the wall of the esophagus. And then you can see here with endoscopic resection, ESD, we can cut all the way down to the muscle. And then when we do esophagectomy, obviously we take the entire wall out of the esophagus. Here's another diagram that explains that, and it has the T stages built into it. So high-grade dysplasia of Barrett's tissue, you'll see that ablation happen, and it happens at a very superficial level. And then again, when we go endoscopic resections and or ablations with liquid nitrogen, you can see we can get all the way down to the muscle there, which can have a value, particularly in more advanced T2 cancers. So what about the National Comprehensive Cancer Network guidelines? These are the standard of care. Anytime you want to know what a patient should be treated for and how they should be treated for any particular type of cancer, these are available to all. And they're multidisciplinary standard of care guidelines. So NCCN does include cryoablation in its guidelines. It has been reported to both be safe and a good utilized technology for patients with Barrett's esophagus and early esophageal cancers. It also has been advocated by NCCN for palliation of patients with advanced esophageal cancer who are having difficulty swallowing. So difficulty swallowing, the medical term would be dysphagia. And so for those patients, NCCN also supports the role of cryoablation. And we'll talk about that in this next section. So that gets into palliative indications of cryoablation. So one thing that's really important for all of us who are taking care of esophageal cancer patients to notice, and this would be anyone from family members taking care of a loved one to nurses and medical staff to physicians, there are 2 things that affect quality of life for esophageal cancer patients. Number 1 is their ability to get adequate nutrition. Adequate nutrition allows them to recover from the various therapies that we give, chemotherapy, radiation, surgery, endoscopic surgical procedures, and so on. Additionally, dysphagia, which is difficulty swallowing. If you don't have the ability to swallow adequately, it can be extremely uncomfortable for patients. Patients will have hypersalivation because what happens is when you block the esophagus, the body reacts by saying, if I lubricate the esophagus more, I will do better. So oftentimes patients will complain of this chronic cough or secretions that keep them up at night. It's because that esophagus is blocked. So even though they have a feeding tube in place, they have significant discomfort, which affects their quality of life. When we think about quality of life, and when I speak to my cancer patients about quality of life, I like to break it down into very simple terms. There are 3 things that I think all humans deserve in order to have a certain quality of life by measurement. One would be to be pain-free. Another one would be to be able to eat, and finally to be able to sleep comfortably. I mean, these are basic things that we would expect all individuals to be able to carry out. And the fact that some of our patients cannot enjoy eating or even tasting certain meals, that can be extremely uncomfortable for them, regardless of whether they have a good outcome or not. And that's where we have an opportunity as interventional endoscopists. So for the oncologist, palliative systemic therapies goal is not meant for curative intent. It's meant to either prolong their life and or reduce symptoms from the cancer. Palliative care is an interdisciplinary medical caregiving approach aimed at optimizing quality of life and mitigating suffering among people with serious and complex illness such as cancer. So as an interventional endoscopist, a surgical endoscopist, a gastroenterologist, what we can contribute to the interdisciplinary team at the very basics is allowing for that quality of life to persist in our patients with esophageal cancer through eliminating dysphagia and allowing for optimal nutrition, which we know happens best not through artificial measures such as feeding tubes or TPN, but really for per-oral nutrition. So I really like this study. This study takes a look at how can we palliate dysphagia by different modalities. So a stent, which is a piece of metal scaffolding, that's a tube-like scaffolding for the esophagus, is something that we can place and into the esophagus through a scope. So on the very top, you'll see all three lines. People start with esophageal cancer, and they all have 100% dysphagia in this study. Now, on the very top line, what happens after people get a stent placed, and how long does it take to palliate dysphagia? So as you go down that top line, 100% of patients started in the stent arm with dysphagia. At 12 weeks, only 13% still had dysphagia after stent placement. For chemotherapy, 100% of patients started with dysphagia, and at 9 weeks after chemotherapy, 50% still had significant dysphagia by their own report. For radiation therapy, we definitely can shrink down the cancer, but sometimes, as we note, patients actually get more inflammation and get worse dysphagia before it gets better. It will get somewhat better. In this study, 100% of patients started with dysphagia in the radiation arm, and even after 16 weeks, 44% still had persistent dysphagia. So clearly there are opportunities for us to palliate patients' dysphagia better. So esophageal stents I mentioned, and as you can see in the prior study, they happen to be the most significant one. I use them in our practice quite a bit. I often will use them in a neoadjuvant approach for patients getting chemotherapy and radiation so they can still eat. Immediate relief can happen over 90%. But there are some serious events. So you want to be an experienced endoscopist and recognize that you can mitigate perforation, aspiration, sepsis, and even mortality by picking the right size stent and the right patient to place the stent in, and also recognizing the extent of the tumor, whether it can hold up to a stent. Additionally, typically in the past, migration has been an issue. We now, in our practice here, because we're in a large, high volume interventional practice at a cancer institute, suture all of our stents endoscopically in place, which does reduce that rate significantly to maybe less than 10%. But again, there's still patients that don't tolerate stents, and this is done under general anesthesia, and it can have chest pain and other side effects. So long-term, it may or may not be the right answer for some patients. Cryoablation or cryospray therapy can be used for palliation of dysphagia in esophageal cancer, and they can be done with or without a stent. So I have had patients that had tumor ingrowth over a stent or through a stent. We've gone back and reopened up that area simply by using cryoablation with leaving the stent in place, especially for some patients who've had stents placed at other centers where they can't be removed. And so I will show you a series of studies that have talked about and have shown the value of palliation with cryospray, and that's what we'll go to next. So here's one such study. This is by 𝘃𝗵𝗶𝗀𝗆, who's at CTCA, Cancer Treatment Centers of America in Arizona. We've done a lot of collaborative research together. He's a great interventional endoscopist with a big focus on esophageal cancer. In this study, it's a retrospective case series of inoperable patients with esophageal cancer. 49 patients were included, 120 total cryospray treatments were performed. It was a multi-center trial involving 9 endoscopists. We had contributed to this trial. And as you can see here, patients had significant response. It was across 10 different sites in the United States, and they were not receiving other systemic therapy. So we're truly looking at just cryoablation and how does it work as a monotherapy for palliating dysphagia. And here's what we found. 89% of patients maintained or improved their baseline dysphagia score after initial initiation of therapy. They had improvement in total global health status. They had improvement in social functioning. I mean, sitting down with one's family or loved ones and sharing a meal with them is an important part of the social interaction, and that is important to our patients. They had a significant decrease in dysphagia, decrease in eating problems, and there were no major adverse events. Here's another trial that we also participated in. This trial talked about cryospray therapy in patients on systemic therapy. It's an ongoing trial, which we're actually pulling data from now. Again, 𝘃𝗵𝗶𝗀𝗆 and our site here in Fort Wayne, Indiana, with the Parkview Cancer Institutes involved in this trial. Here's our interim analysis on 24 patients. They all have different stages of esophageal cancer, as you can see here. 71 cryoablation procedures performed, a mean of about 2.9 treatments per patient. At the initial 2-month follow-up, and now we have greater than 14-month of follow-up on many of these patients. Patients had significant improvement in their dysphagia scores. Only one patient had an issue of an adverse event. So that's 4% of all enrolled patients. Here's some really nice visuals that help people understand what happens here. So you can see on the very top series, a patient with an esophageal cancer that involves about a quarter to a third of the lumen. And you can see what happens through a series of ablations and how that essentially melts away. Same thing on the bottom. The bottom's another patient. You can see the series of progression from left to right on your screen, where an esophageal cancer essentially melts away with a series of treatments. This is just with 2 sessions. So looking up to down now, you can see 4, 3, 6. These are different subjects that are enrolled in our trial. And you can see how, again, the cancer melts away. So on the top part of your screen, in each column, there's a patient, and you can see what the response looks like. As particularly for subject 3, you can see there's a complete, almost eradication of their cancer simply through cryoablation. Same for subject 6. Subject 6 had a complete response, which is very interesting to see, and was in a difficult location. It's actually on the cardia side of the GE junction. So these pictures tell the tale of how we can help palliate patients with this amazing technology and how well they respond. Here's another additional study. This study we actually presented at GI ASCO in 2020 and then subsequently in 2021. So at ASCO is the American Society of Clinical Oncology, and our GI conference happens every year in January in San Francisco. And it is a major conference where we talk about latest and greatest in technology and research around GI cancers. So in this study here, our study design was a prospective, open label, non-controlled, single-arm, multi-site study. We enrolled up to 50 subjects, 12 different sites across the United States. The study duration, each site enrolled patients for approximately 12 months. Our primary endpoint was to take a look at baseline dysphagia score. Our secondary endpoints were to look at overall survival, time to additional interventions. And this was monotherapy. So this was not patients on chemotherapy like the prior trial that's still going on. And here's what our outcomes look like. And so 𝗃𝗏𝗀𝗃, who I think spoke earlier today and is part of ECAN, was one of the enrolling sites. Nick Shaheen is a mentor of mine who talks about Barrett's esophagus, has multiple publications on that, all the way over to ourselves, 𝘃𝗵𝗆 Kashami, and some other sites. And what you can see here, and the bottom line of these results are, patients did very well in terms of palliation of dysphagia. It was direct improvement in quality of life as objectively measured for all of our patients. I will point out one particular subject. This is a subject of my own, a 75-year-old male. He had a previous history of head and neck cancer. He had an initial esophageal cancer diagnosis back in 2014. I still follow this patient to this day. Esophagectomy occurred. He had a recurrence. He then, at the recurrence, has a T4 cancer. So a very large, bulky cancer comes back at the recurrence. And what you can see here is the baseline cancer on the left, post 2 treatments, and then on the right, you see staple lines from the esophagectomy, and the cancer is completely melted away. These were the different treatments that we did, 26 days, 46 days, and so on. And the bottom line for this subject is this patient is now 3.5 years out from any treatments at all, has negative PET scans, negative endoscopy, negative biopsies, and has disease-free survival. And we expect that he will do very, very well. We are continuing to follow him out to 5 years, but it is a great example of a patient that got complete remission even after a recurrence after esophagectomy with this technology. Does this happen for everyone? No, but it definitely raises the question in the third portion of the lecture today, which is, can we utilize cryospray technology in a meaningful way to create salvage therapy for treating cancer? So we're not talking about palliating symptoms now. We're talking about direct treatment with an attempt to cure patients. So one of the first points, and I mentioned this in the video that you saw previously, cryospray technology is an adjuvant treatment post-endoscopic mucosal resection in high-grade dysplasia and early esophageal cancer. We do not like to leave Barrett's tissue behind once it's turned into esophageal cancer. And after we've eliminated the esophageal cancer with chemotherapy, radiation, or surgery, that cuff of Barrett's is important to notice and get rid of. And we'll point out a study that's shown that before from Moffitt Cancer Center, where in the areas that I trained. But it can also be used after endoscopic resection. So I have patients that have stage 1 esophageal cancer. We'll do an endoscopic resection, and then we'll use cryospray technology on the remaining areas of Barrett's tissue to make sure that it does not reoccur into an esophageal cancer. And so here's great data showing that efficacy. Arvind Trinidad, 𝗃𝗏𝗀𝗃𝗀𝗃 were involved in this study, as well as Doug Plaskow out of Harvard. And what you can see here is The aim of this study was to take a look at patients with Barrett's esophagus who received endoscopic mucosal resection and then got additional cryospray therapy. And what they were able to show is cryospray is an effective endoscopic tool for eradication of Barrett's esophagus after endoscopic resection. So we can utilize this as an adjunct to already existing technology if we have it available for us and we're cognizant of its indications. Another example of treatment with cryospray. Cryospray can be used for treatment of residual Barrett's, and I just mentioned that to you. I showed you a video of that. Chemoradiation does a great job of getting rid of esophageal cancer, and we often will combine that with esophagectomy based on NCCN guidelines. However, as I mentioned, and as you saw in the video, if there's residual Barrett's tissue, we already know that that particular patient has a more aggressive biology of their Barrett's tissue. So that means that that Barrett's tissue has already turned into cancer once. We would not want to leave that behind, or we'll get local recurrences. And here's a study from 𝗃𝗵𝗿𝗀𝗍, who is the original individual who taught me how to utilize Barrett's esophageal ablation through cryospray back at Moffitt Cancer Center when I was a GI fellow in 2011. And so what 𝗃𝗵𝗿𝗍𝗀 and his group showed out of Moffitt was that patients will have Barrett's esophageal tissue left behind after chemoradiation has cured them of their esophageal cancer or eradicated the esophageal cancer. And their objective was to say, can we utilize cryospray for patients that still have that cuff of Barrett's esophageal tissue to try to prevent recurrences in these patients? And what they saw through their conclusion after taking a look at a series of patients in various stages with various amounts of Barrett's esophagus, that they were actually able to safely eradicate persistent Barrett's esophageal tissue. So this is something important for everyone to note. Why would we go back and do an endoscopy on somebody who's had chemotherapy, radiation, and or esophagectomy? We sometimes like to look for that cuff of Barrett's tissue, and if we find it, it's important for us to eradicate it. And cryospray is one of the safest ways to do that. As I mentioned before, thermal energy is a way that we eradicate Barrett's esophageal tissue. There's great data for the utilization of RFA and Barrett's, but we wouldn't often do that over anastomosis. In fact, that can be a relative contraindication. We do utilize cryospray in this scenario. So it's important to have different tools in your toolbox to lead to the best outcome for your patients. Cryospray can also be used as a salvage treatment for locally advanced esophageal cancer. A study from Bruce Greenwald and Wolfson and this group also took a look at cryospray for esophageal cancer, specifically looking at safety and efficacy. What they wanted to do was a multi-center retrospective cohort study of patients with esophageal cancer over a 3-year period of time. Their main outcome measurement was complete eradication of residual esophageal cancer in these patients, and were there adverse events? Is it safe? And so they looked at 79 different subjects with various stages of esophageal cancer, from T1 all the way out to T4 disease, and they followed them and giving them a series of treatments with cryospray therapy. And what they found was patients tolerated the procedure well, it was very safe, and short-term follow-up did show there was efficacy in eradicating esophageal cancer for some of that cohort of patients. Maybe not everyone, but some of that cohort, particularly those who had mucosally based cancer at earlier stages. So clearly the applications for the utilization of this novel technology are rapidly expanding. And there was a really nice article in World Journal of Gastrointestinal Endoscopy that pointed this out. And one of my favorite lines from that review was, unlike other endoscopic ablation techniques, the unique mechanism of action and depth of injury allow cryoablation to be used effectively in flat or nodular, meaning raised disease. It can be combined with other modalities, as I've talked about today, such as endoscopic mucosal resection or even radiofrequency ablation. Its esophageal applications stem well beyond Barrett's into ablation of early carcinoma, palliative debulking of advanced carcinoma, and reduction of tumor ingrowth into stents placed for dysphagia. This technology is still only the tip of the iceberg in terms of our understanding of how it can be fully utilized. There are clearly more studies that need to be done, but expanding its utilization for a variety of indications, as you can see from the lecture today, is really the future for us in its utilization in our armamentum of tools for esophageal cancer treatment. And one of the greatest questions that I like right now is, can we increase cure rates by adding cryotherapy to other modalities of therapy? So it's not subtractive. It doesn't mean we can't do surgery, chemotherapy, or radiation, But as all of you know, the 19.5% 5-year survival for patients with esophageal adenocarcinoma, there's clearly room for growth and room for better outcomes. And that's the whole purpose of ECAN's mission and all of us who are taking care of these patients. So cryospray therapy may be one way to do that. And is it safe to do that in concurrent chemoradiation? What's the maximal dosimetry that we need to use? Is that dosimetry different for patients with a neoadjuvant approach, meaning that we're going to give them chemoradiation? Can we add cryoablation? And is that different than the dosage we're using for salvage and palliative therapy? And does cryotherapy stimulate anti-tumor immune response? So in other lectures you may have heard, immune therapy has becoming a new tool in our armamentarium of treatment of patients with esophageal cancer. That data is becoming more and more supported, and now we're utilizing it soon to be standard of care as part of our chemotherapies. But can we actually rev up the immune system and stimulate it by giving cryospray therapy? It does not actually change a lot of those antigens, because when we ablate it, as I mentioned previously, that cellular matrix is maintained. Unlike with radiofrequency or thermal ablation technologies, we're actually maintaining those cells. So can we make the immune system recognize them as foreign and make it even more potent to add immunotherapies? And so there is a nice trial from 𝘃𝗶𝗱𝗏 out of Virginia Commonwealth University, Medical College of Virginia. And what they looked at was utilizing, in a neoadjuvant approach, cryotherapy in addition to chemoradiation. They enrolled 21 patients, 14 locally advanced, 7 metastatic, 1 session of cryotherapy prior to neoadjuvant chemoradiation. There is a median of 2 sites per session, 30-second ablations. And they took a look at what happened with these patients. And what they found was long-term 1-year complete remission in 44% of these patients, even the ones that were not allowed to have surgery because they were not candidates for that. So there does appear to be, in this small cohort of patients in this single study, an opportunity for us to be additive to standard of care. And so obviously more studies are needed, but right now we know that there are some further opportunities as we explore and do more research on this cohort of patients utilizing this novel technology. My last slide to summarize some of what we talked about today. There are a myriad of applications for cryoablation. It's important for high volume centers and cancer institutions to recognize this technology and add it to its already robust armamentarium of care for patients with esophageal cancer. We can utilize cryoablation for patients that have a high risk of stopping anticoagulation for ablation of both Barrett's and esophageal cancer. So for my patients who may already have a DVT or a blood clot, I don't stop their blood thinners when I'm doing cryoablation, which is unique and interesting and important. We also can utilize it for salvage ablation for those patients who maybe failed radiofrequency ablation. We can utilize it as an adjuvant treatment after endoscopic resection in patients with high-grade dysplasia and esophageal cancer. We can utilize it for the treatment of residual Barrett's tissue after we've eliminated an esophageal cancer and there's Barrett's left behind. There are multiple studies, and I pointed out 3 today, that have showed palliation for dysphagia and esophageal cancer, and it's now part of the NCCN guidelines for utilization for this indication. We also can use it for salvage treatment for locally advanced esophageal cancer, both in patients who have a recurrence or in individuals who may not be resectable, and that allows us to salvage treat them, meaning that they have a recurrence or there's still residual tissue left behind. We can add cryoablation to them. We can use it with or without chemotherapy. And then finally, as the last subset of patients we pointed out, there's probably a role of adding it potentially to chemotherapy or immunotherapy that needs to be further explored to potentially get better outcomes for our patients with this devastating disease. I thank all of you for tuning in. I know I gave you a lot of information. I want to give an opportunity for everyone to ask questions and for us to interact.
Dr. Sharma, thank you very much for that informative presentation. If folks have not done so already, at the bottom of the screen, you'll see in the chat, please feel free to enter your questions there. And we have one question that's here right now that just popped up. How often can spray cryotherapy be done? And do you have any idea how long each treatment lasts in reducing dysphagia?
Yeah, so the question is in regards to, how many times can we do this? And some of that's dependent upon the patient. So as you all probably recognize with cancer treatments, each patient's unique, each patient is special, each patient has a different burden of disease. So I have patients that have required only a single session to kind of get them to where they needed to be, depending on how much bulk of disease they have. But I have patients who have gotten these types of treatments every 2 to 4 weeks and done so for over 10 sessions. It really depends on their symptoms, and it's important for us to get feedback from the patient as to how much dysphagia they have so we can tailor that. As far as how many treatments do you need, as you saw in one of those 3 studies, that was the first study that I showed you for palliation. Oftentimes after 2 sessions, patients have a significant reduction in their dysphagia. So we start to expect a good response after about 2 sessions.
Okay, great. What are the predominant side effects associated with liquid nitrogen spray cryotherapy?
Yeah, so it's really important to think about the patient consideration. So how is it different, let's say, than radiofrequency ablation? So radiofrequency ablation is used mainly for Barrett's, not really for esophageal cancer. And in those patients, we often hope that they don't have any discomfort, but some will experience some significant chest pain as we're using burn or thermal energy to treat those patients. With cryoablation, I find that my patients usually experience little to no discomfort at all. It is not destroying the natural cellular matrix, so I think that's part of the reason. We're not using thermal energy, so there's less of that sensation of burning afterwards or chest pain. So patients seem to tolerate it quite well. They seem to prefer this if they've had both radiofrequency ablation and cryoablation, and we utilize it obviously for the right indications. But I expect most patients not to feel much. The patients that I'm treating are getting monitored anesthesia care, so getting propofol sedation as opposed to conscious sedation. I do know some individuals who have given the conscious sedation, meaning Versed and fentanyl, with utilizing cryoablation. But in our practice, we use non-intubated propofol with the anesthesiologist.
Is there an optimal dose or treatment regimen for esophageal cancer? And is it uniform across the board in terms of, does it vary by disease state? Like early stage disease is treated differently than it is for a curative intent versus end stage?
Yes. So, it depends on what you're trying to achieve, and that's aligned to the patient's goals. So along that question line would be, if a patient is there to get palliation of dysphagia, we know that our primary endpoint then would be to measure their oral intake, and maybe that's less sessions. If our goal is to completely eradicate the disease, often that will require more sessions. As far as understanding the dosimetry, it's a pro and con in cryoablation. I'd say the pro about cryoablation is we can truly tailor it depending upon what our outcome is. So meaning we can do 30-second cycles or longer, and I have done longer. Additionally, some patients only need 20-second cycles. And so it's quite variable. So there's not an optimal defined dose for esophageal cancer. I would say I typically start with 30-second, 3 cycles, as I mentioned in one of our slides. And I will bring patients back on a 2 to 4 week basis in the beginning, trying to quickly palliate their dysphagia and then really get ahead of the disease. I don't stop their standard of care. So if they have chemotherapy going, they continue to get chemotherapy. We don't typically do it at the same time as radiation because, as you know, radiation is daily for 6 weeks, so that typically we won't do. But we don't stop their chemo or immunotherapy either. We've done it on both. I think I'd be a little bit more cautious with immunotherapy because we just don't have long-term data yet. But otherwise, I think they continue to get standard of care, and this is only additive, not subtractive.
That's great. Speaking of radiation, this other question is how does cryotherapy compare to radiation in terms of number of sessions, time to dysphagia relief, and complications?
Yeah, so, number of sessions required to palliate dysphagia is the question. Is that right, Patrick?
Correct, in comparison to radiation.
Oh, yes. So radiation, you saw one of the database slides there, at, what was it, 16 weeks or so, for 12 to 16 weeks, 44% still had residual dysphagia. So with radiation, if my patients are going to be part of that 56% that respond. I would expect them to feel that in about 8 weeks, 6 to 8 weeks on average. Some patients get it less than that. Some patients takes a little bit longer. That's the limited amount of data that we have that's followed and looked at that specifically. For cryoablation, I would expect patients to experience a relief in their dysphagia after about 2 to 3 sessions in typical, and I bring them back at an interval of about 2 to 4 weeks. So, and I know Tufik, if I can speak for him, he also does the same thing at CTCA. So being a little bit aggressive up front, we'd expect that we should be able to palliate their dysphagia within a 2 to 6 week period.
Okay.
Comparing that to stents, because I think I saw that question as well. So there's pros and cons to both. So you saw stents, right? I mean, stents had only 14% of patients still had dysphagia at 12 weeks out, and most patients had an immediate response from esophageal stenting, as you would imagine. So you're essentially taking metal scaffolding, putting that cylinder inside, opening the esophagus back up. And so it is one of the best ways to immediately alleviate dysphagia. How do I pick stent versus cryoablation is an important question. And this is, again, partnering with the patient. So if the patient does not want to undergo anesthesia and have multiple sessions, if they may have a worse ECOG status, so their overall function is not as good, a stent is a very reasonable choice for those patients, especially if you have the capability of endoscopic suturing. Because one thing we worry about stents is if you're not suturing, the migration rates could be 50%, as high as that. So that is an issue. But if a patient says, look, I think this could be additive to chemotherapy, as I pointed out, that can be a value, and I don't like the concept of having a foreign body inside, or my lesion is extremely ulcerated, has a chance of bleeding, or they can't tolerate a stent, I think cryoablation is very good for that. The con, of course, would be that they have to get multiple sessions of sedation and a procedure. So again, no perfect. It's really about partnering with the patient, understanding their goals, and then looking at the totality of their cancer care treatment. This is why multidisciplinary care has to be the stalwart for any type of cancer treatment. It is not simply about chemotherapy, radiation, or surgical procedures, esophagectomy, ablation, so on. It has to be a team-based sport that's really revolving around the disease and patient.
Great answer. Next question is, what can patients expect post-procedure in terms of diet and resuming activities post-cryo?
Yeah, that's a great question, because patients want to get back to regular activity. That's the goal of what we're trying to do. Same day, because they get sedated, they obviously can't drive, but most of my patients will be eating that day, or all of them for the most part, unless they have severe dysphagia. The degree of what they can and can't eat depends upon how severe that cancer is and what degree of the lumen is still blocked. And then patients go back to regular activity right away within reason. Like I said, certain things, driving, heavy exercise might not be appropriate for patients.
Okay, and I believe that's it for the questions.
I see the 2-minute wrap up here. I just want to thank ECAN. Thank you, first of all, for STERIS for sponsoring ECAN and sponsoring this particular session. Also, just thanking ECAN and ECAN leadership. Esophageal cancer is one of the highest increasing cancers in terms of incidence in the West. So that would mean Europe, Canada, and America. I have personally lost a really good friend of mine from college, and he passed away with 2 young children at 38 last year. And just to see people devastated from this disease, take care of patients with this disease, it means a lot to myself. I'm sure it means a lot to Patrick and STERIS, but that ECAN would put this together, inform patients, inform family members who are helping us care for patients, and allow us to learn from one another as medical staff, scientists, as we continue to try to make a dent in this devastating disease. So thank you to everyone for tuning in, and thank you for ECAN for your leadership and opportunity to speak today.
Thank you, Dr. Sharma. This concludes today's presentation. Thank you for joining us today. And for more information on TrueFreeze spray cryotherapy, you can visit steris.com/TrueFreeze. And We want to thank everyone for their time and attention, and thank ECAN for the opportunity to come on and support this great organization. Thank you very much.